Welcome to NCPDP Unscripted, the podcast where healthcare meets real talk. Each episode, we will dive into unscripted conversations with industry leaders, changemakers, and innovators, discussing the challenges, breakthroughs, and behind-the-scenes stories you won't hear anywhere else. Whether you're on your morning commute or taking a break between meetings, settle in because it's time to get unscripted.
Well, Matt, welcome to the NCPDP Unscripted podcast. Really excited to have you on today.
It's great to be here. Thanks for having me.
Yeah, absolutely. So I know some of our members know you. I know you've presented at our work group meetings before, but would love for you to share with our audience who you are, where you work, and what you do.
Sure. So my name is Matt McGrath. I'm the Vice President of Pharmacy Strategy for Experian Health. I've been with the organization just over 11 years. And Experian Health normally is known as a revenue cycle management company for hospitals. So my job is to take hospital assets and figure out where they play nicely in pharmacy and in surrounding markets. So we work with retail pharmacies, infusion pharmacies, pharmaceutical manufacturers, and we have over 50 products in the healthcare space today.
Great. I think I know you guys from my old Dr. First days. You guys do identity proofing for providers as well.
Yes,
correct?
one of the benefits of being part of a large organization like Experian is we can also leverage Experian products and assets, and identity proofing is one of those products from the Experian portfolio that we've brought into healthcare as well.
Excellent. So want to talk a little bit about, I know we have partnered with you guys for our Patient Experience Identifier, which allows organizations to essentially match patient records. Can you just, let's start out talking a little bit about that and what that does for healthcare and for pharmacy.
Sure. So the Patient Experience Identifier, when we think about how healthcare today matches identities and records within ecosystems, typically those systems are probabilistic matching algorithms. So I have a database of patients, and I have a patient with a name, a date of birth, and an address, and then maybe another record for a similar name patient, maybe the same date of birth, some common elements that are shared. So probabilistically, those systems then match those identities or keep them separate if there isn't enough information to make a complete match on that individual. So with the PEI, we're leveraging that type of probabilistic matching algorithm, but using a referential database as well, which is basically credit type information, so information that normally isn't present in a healthcare ecosystem, to find more matches on those individuals. So an example of that would be, as part of a credit bureau, there's data on your historical addresses. So a credit bureau knows your last up to 25 addresses. So now an individual who has the same name and a date of birth that lives in Sacramento, California, can be matched with a person with the same name and the same date of birth that lives in Rochester, New York, because there's this historical reference database available to say this person packed up and moved cross-country. Same thing, maiden names versus married names,
Right.
nicknames, all of this type of information can be available within that referential database to improve upon that matching algorithm above and beyond that probabilistic matching.
Very interesting. I know it seems like today in the healthcare, we just use a lot of first name, last name, date of birth, and I think zip code, or like there's like 5 data elements. So what you guys are doing is basically taking that a step beyond that to make
Correct.
sure that patients are matched.
Correct.
I've been recently, and I think CMS just announced their CMS Align Network, which is going to really fast forward patients being able to get all of their patient records, whether it's on their phone or in a portal, something like that. And it's interesting because what I've been hearing is in order to do that, right, you got to be able to match the records. Right. And it does worry me, right? I mean, for my name, Pooja Babur, I don't think there's a lot of Pooja Baburs out there, but, John Hill, for example, our COO, there could be multiple John Hills. So talk to me a little bit about how do you push back? Because I know, CMS and others are saying, hey, we don't want any kind of patient identifier, any of that. Like, how do you answer those questions?
So interestingly, when we talk about this patient identifier, right, they already exist today.
Yeah.
Every healthcare provider that you go to, their application that they're using to manage their practice, their pharmacy, all has some type of probabilistic matching engine, and there's some type of unique identifier that is limited to that system, right? It's enclosed in the four walls of that healthcare organization.
Yeah.
So as part of this process, we're looking at an experience identifier. We're not really looking at a unique patient identifier,
Right.
but the idea here is to not only link records, but how else can we improve the overall patient experience? So if I'm a patient who now is having dialysis treatment, right, would my provider like to know if I have reliable transportation? Because obviously I have to go potentially to a clinic multiple times a week for dialysis.
Right.
So having an experience identifier, which is the foundation for matching that identity, can also be augmented with other types of data sets. So if we think about a big buzzword in our industry today is social determinants of health, right? And social determinants of health is really non-clinical factors that affect healthcare outcomes. So using that dialysis example, would it be great for my provider to know that I do have a reliable car, or I live close to public transportation? Or if I don't, then as part of that treatment, do they need to figure out how to get me into the office, or do they have to visit me at home? So above and beyond just understanding the person, there's this ability now to augment these records with additional data, socioeconomic data, financial data for patients who may qualify for free drug programs, to really improve that patient experience above and beyond just going to the provider, getting treatment, but then how do we keep them compliant?
Yeah, I love that. And I think, from a pharmacy standpoint, we always say pharmacists sometimes know even more than the doctors, right? What's happening with the patients. And the example I always use is a doctor prescribes something that needs to be refrigerated, and the person's like, well, I'm, in between homes right now, right? I'm in a shelter, whatever it is. And so the pharmacist gets that information. So being able to connect that information and even allow the pharmacist to potentially be able to do some of that as well. That's fantastic. So we did do a pilot program with you all. There is the National Facilitator Model we've been working with STC Health on. I heard you talk about that a couple weeks ago in a meeting and just kind of describing the pilot program we did and what we were able to prove with that. Can you just share a little bit about that?
Sure. So the National Facilitator Project obviously changed direction a little bit as a result of COVID. And so the pilot program was to track COVID vaccinations and follow-up vaccines. And so we took in a data set through our partnership with STC and NCPDP, and we took in a data set of about 100,000 patients representing 4 states and several regional pharmacy organizations. So we're not talking about your national organizations where, for folks like you and I who travel very frequently, there's a likelihood that we've gone to a national retailer in multiple states. And so we took in this data set, and what we found was, as we ran all of the data through the Patient Experience Identifier, we found several things that were very interesting. One was that 114 patients in this data set went to 2 different pharmacies in 2 different states to get their initial COVID vaccine and their follow-up booster shot. Now, we all know that polypharmacy exists, right? So we didn't technically prove anything new. But to see it in reality for something as simple as a booster shot was alarming, right? And if we think about the long-term plan for the facilitator model, if we can use the solution in a case for something as serious as opioid abuse, right? If we're seeing polypharmacy exist today for something simple like a booster, we know that those bad actors can game the system and go to multiple pharmacies in multiple states to access multiple prescriptions for the wrong reason. The other really interesting thing about the pilot program was the amount of address information that was out of date. So as part of the process for the PEI, as I mentioned earlier, you can augment data. We were augmenting the addresses. So updating demographic information, updating phone numbers to make sure that those pharmacists could reach those patients in case there was a follow-up that was required.
Right. So tell me a little bit about what else you're doing in the pharmacy space.
So today, as I originally mentioned, right, our core business is revenue cycle management. So we are a medical claims clearinghouse for infusion pharmacies, retail pharmacy clinics, pharmacy services. But our big focuses right now, especially around that PEI, is how do we expand the use of the PEI into other areas of healthcare? And so one, as I mentioned, was social determinants of health, where once we have this foundation where we have identified an individual, we can then understand these socioeconomic risk factors that may affect their healthcare outcomes. So whether it's transportation, food insecurity, housing instability, we have those factors that can be supplied. Another thing with the PEI, again, going back to understanding that identity, is we're currently working on a project where we're helping to assist in e-prescribing. I don't want to say fraud, but maybe suspicious activity around e-prescribing.
Oh, interesting.
So seeing a prescription that is being sent in to a provider with a historical address, not a current address for an individual. And so does this represent potential diversion of prescriptions? So having this type of data, which again typically isn't in the healthcare ecosystem, adding it to your process, it's just another little breadcrumb to maybe finding an issue and then finding a solution to that issue.
That's great. I didn't realize you guys were doing that. I know CMS is like, how do we track this, fraud, waste, and abuse with electronic prescriptions? So that's great. All right, so we are ready to wrap up. I'd love to just get your thoughts about, there's so much swirling right now in our industry, all about, again, the patients getting their own records, all of that. What are you hopeful for, and what do you expect to see in the next couple of years?
I think there's no silver bullet, right? There's so many things that need to happen to improve the patient experience. But the idea here is that when organizations come together here at NCPDP and collaborate together, that's the big win. So we can all work together because we're all working towards a common goal and a common outcome, which is to improve that overall patient experience. And this is a great place for us to do that.
Yeah, great. Well, Matt, thank you so much for joining us today. And looking forward to seeing how we start to move things forward around this PEI.
Sounds great. Thanks for having me.
All right, thanks.
That's a wrap on this episode of NCPDP Unscripted. Thanks for joining us as we explore the voices and ideas driving innovation in healthcare. If you'd like to be a guest on the show or have topic ideas you'd love to hear us cover, we want to hear from you. Until next time, stay curious, stay connected, and stay unscripted. Our podcast is proudly sponsored by Marks Productions.